Okay. Uh, oh, thank you so much. I think I'm going to go ahead and get started. We're going to just close the door so um, we don't hear the other conference going on there. Okay. Thank you so much. Oh. I'd like to thank the organizers of TASTRO for inviting me here today and all of you for attending this afternoon. My name is Lilie Lin. I'm a GYN radiation oncologist at the University of Texas MD Anderson Cancer Center. Can you all hear me okay? Please let me know. I do have a few interactive questions during my talk, so if you log into the website, you can, answer the poll question. They're very simple, straightforward, just about your practice here. So this is the eContouring for gynecologic malignancies session. So here are my financial disclosures. I don't think any of them are necessarily relevant today. So I'll start out by talking a little bit about eContouring for post-hysterectomy patients who require adjuvant pelvic radiation, either for endometrial cancer or for cervical cancer. So just as a brief background, this is the TIME-C study that was conducted largely in North America and some other multinational sites that compared external beam radiation given with standard 3D conformal radiation or intensity modulated radiation. And so in that study, the standard radiotherapy fields are on the right, and the IMRT fields planning or contours are outlined on the left. And they use the RTOG atlas. So that just as a brief background, here are the eligibility criteria for TIME-C. So women with endometrial or cervical cancer requiring postoperative pelvic radiation or chemoradiation were eligible. They received 45 to 50.4 gray and chemotherapy if appropriate. And this was a 1-to-1 randomization. Oops, did I go the wrong way? So the primary endpoint was bowel toxicity using the EPIC patient-reported outcome questionnaire, and this is acute toxicity, and they found that there was a statistically significant difference at week 5 in the patients that received IMRT radiation. And then long-term PRO CTCAE GI toxicity follow-up on TIME-C, they also showed that in patients that got IMRT, there was a statistically significant decrease in the amount of toxicity observed in those patients compared to those patients that got 3D conformal radiation. So largely, in our practice at MD Anderson, for women requiring postoperative pelvic radiation, we use intensely modulated radiation. So this is the RTOG Core Lab Contouring Atlas. You can get it on this website. And it was, the contouring guidelines were updated just in the last year. And this is important because there were some aspects of IMRT contouring for gyne malignancies that was missing from the initial atlas, including how to contour the periortics. And so I just wanted to start out by talking a little bit about the nodal CTV contouring, which can also be applied for patients who require IMRT for intact cervical cancer. But this is if you're interested in targeting the presacral lymph nodes, and this would be important for patients who have cervical cancer or for patients with uterine cancer who have cervical involvement. The presacral nodal region would be the region in front of the S1, S2, or down to S3 in a patient with cervical cancer, and it's about 1.5 centimeters wide here, and anteriorly, about 1.5 centimeters from the sacrum. And so the internal and external iliac nodal CTVs, are as shown here in this atlas. The external nodal CTV contour, inferiorly, you stop stop moving anteriorly when the vessels move into the inguinal canal. As you can see here, you would stop this contouring here. And then inferiorly, the obturator nodal CTV ends where the obturator vessels enter the obturator notch, as you can see here in panel F. And then in panel E, they've also noted a circumflex node. This is very rarely involved in patients with endometrial or even in patients with cervical cancers, though we don't typically include that unless there's a patient with grossly involved nodes and you're concerned about that region. So just a little bit more in depth about when to stop inferiorly the anterior nodal CTV contour. So once the external iliac vessels start to enter the inguinal canal, you don't have to, you can stop your anterior contour here, because this nodal region here is very rarely, involved in women with uterine or cervical cancer who don't have lower vaginal involvement. And this is just a larger view of when to stop the inferior contour of the nodal CTV in the obturator region. So this is the obturator canal here, and you can see the vessels, just entering that region. So just as a couple of examples, this is a 59-year-old woman with poorly differentiated squamous cell carcinoma of the cervix. She had no FDG avid pelvic or para-aortic nodes, but had bilateral parametrial invasion with extension into the vagina, as well as the posterior wall of the urinary bladder. She had bilateral hydronephrosis, likely due to involvement of the ureters and sub-centimeter non-specific lymph nodes. Oops. Oh, yes. So I just wanted to show you the nodal CTV contours for her. You can see that in yellow. And for patients with cervical cancer, we also obtain a pelvic MRI as well and fuse that together in our system. We can't always get the MRI in treatment position because frequently they will have already obtained a diagnostic MRI before we've seen them, and we can't obtain a second one due to the cost of this. So I also wanted to show you the sagittal and coronal projections of those contours here. And we typically prescribe 45 gray initially with either a 55 gray simultaneous integrated boost or a 50 gray simultaneous integrated boost to the nodes, followed by a sequential nodal boost. In this case, because her lymph nodes were very small, or at least the ones that we could see on her CT simulation were very small and we weren't sure they were involved, we felt comfortable prescribing to 55 gray and 25 fractions. And this is the dosing that the Embrace group uses. Oh, it looks like I've just showed the dose color wash isodoses as well in this patient. So just this is our first poll for this afternoon. What is your practice pattern? How do you boost enlarged nodes for patients with locally advanced cervical cancer? Do you use a simultaneous integrated boost? So similar to perhaps what the Embrace group recommends or does in their protocol. So 55 gray and 25 fractions to gross pelvic nodes and 57.5 gray and 25 fractions to gross periaortic and common iliac nodes, or do you prefer a sequential boost? Or as I mentioned, what we often do in our patients is a simultaneous integrated boost of a lower dose per fraction. So instead of 55, we do 50 in 25 fractions, followed by a sequential boost of between 6 to 10 gray, depending on the dose to the lymph nodes from brachytherapy. So I don't know if we can get the poll. Yeah, I don't know how this works. Does it come up? Oh, okay. Thank you. Okay, so it's kind of split between the embrace fractionation and perhaps kind of what we do, number C, what we do at Anderson too. Okay, excellent. Thank you for participating. So I wanted to move on to para-aortic nodal contouring. This wasn't covered very well in the initial, actually I don't think it was covered at all in the initial contouring atlas through the RTOG, but there have been several subsequent publications on this in the recent RTOG, or the recent atlas updated this to include this area. So in endometrial cancer, typically the superior border would be 1 to 1.5 centimeters above the left renal vessels, and we recommend using a non-contrast CT scan for contouring, as contrast with the CT scan can distend the inferior vena cava, causing you to want to maybe make these contours bigger than they need to be. For patients with cervical cancer, the superior border would be at the level of the left renal vein, or at least 1 to 2 vertebral bodies above the highest node, or at least in our practice. So as shown here, you can see the inferior vena cava here, and then the contour, doesn't need to completely encompass the vessels, as shown here. And certainly on the right side, you can have a smaller right lateral expansion, because studies have shown that the majority of nodes, at least half, are either in the left para-aortic or in the interaortocaval region, and less than 10% are in the right paracaval region. And per the atlas, this contour anteriorly can be flat. It doesn't have to be concave, due to the interaortocaval nodes. And this is, again, just a different level for the para-aortic contours. Oh, and you can see here that the inferior vena cava is quite distended from the contrast, so you don't have to include the whole thing. Okay, so here's our next poll. When you do treat the para-aortic lymph nodes in patients with locally advanced cervical cancer, when do you treat the para-aortics in patients with locally advanced cervical cancer? So A, only when they are grossly FDG avid on a PET scan, or B, when common iliac lymph node is enlarged, or say FDG avid, or C, when there are 2 or more positive pelvic lymph nodes on imaging, like say grossly positive, so greater than 1 centimeter, or other. And there's certainly no right or wrong answer. It's more just an understanding of practice patterns. Oh, here we go. So only when grossly FDG avid in the para-aortic region, so it's about 1/3 of y'all said this, and then when common iliac node is enlarged, not quite half, and then there was some other combination as well. Okay, I think that's very good. Okay, next. Oops. Oh, so this is our next poll. So this is for patients with endometrioid carcinoma. So when do you treat the para-aortics in patients with positive pelvic sentinel lymph nodes with endometrioid carcinoma? I guess this is assuming that you all routinely now do sentinel nodes in patients with uterine cancer. But A, only when grossly enlarged lymph nodes in the para-aortic region are seen on imaging, and this can be PET imaging, MR imaging, or CT imaging, when there are 2 or more positive pelvic sentinel lymph nodes, or when there's 1 or more sentinel lymph nodes and deep invasion, deep myometrial invasion, or some other combination that I didn't list there. Okay, so about 70% only when grossly enlarged in the periodic nodes on imaging, when 2 or more positive pelvic lymph nodes, 15%, and then when at least 1 with deep invasion any grade. I realize this is an eContouring session, so I think when to treat the pelvis in patients with positive sentinel nodes, whether they're micrometastatic or with isolated tumor cells or macrometastatic, it's very controversial. In our practice, we often do an extended field if there are 2 or more positive pelvic nodes and there's other high-risk uterine factors such as deep myometrial invasion or high grade. And we always do that with IMRT, so hopefully the toxicity will be less in the long term. Oh, okay. We can go on to the next slide. Okay. So then I wanted to talk a little bit about contouring the vaginal ITV in the post-hysterectomy setting. So ideally, we would scan patients with an empty rectum, but this isn't always possible because our patients don't routinely get enemas. So oftentimes we're scanning in this situation here in panel B with a very full rectum. But if that's the case, then we'd recommend extending the vaginal ITV anteriorly into the bladder if the rectum is empty, or if it's very distended, extending that ITV posteriorly to within 1.5 centimeters of the posterior rectal wall, to account for this. Because we can scan patients with a full bladder and an empty bladder, but a little more challenging to ask patients to have a full rectum and then scan them with an empty rectum too. But this is perhaps why we also do daily, or weekly combing CT to observe this. So these are just some additional examples of vaginal ITV contours in a patient. So the CTV is in this pink color, and then an ITV is in blue. You can see that it does extend into the bladder to account for the vaginal motion with bladder filling. With a full bladder, it tends to stretch the vagina superiorly as well. So I wanted to talk a little bit about the use of IMRT for patients with intact cervical cancers, as there are several controversies, including, the extent of contouring. So, for example, in a patient with parametrial involvement or more extensive uterosacral involvement, do you contour the entire mesorectum or more limited contour? How do you account for organ motion on a day-to-day basis? Do you use a plan of the day, or do you treat with a full bladder, or do you do a full and empty bladder simulation to account for this? So this was an atlas that was published a number of years ago now through the RTOG, and they used their atlas was based on pelvic MR imaging. So it's a very nice atlas and kind of goes through each of the substructures for contouring. So in green, you can see here is the parametria, and in red is the gross target volume, or pink, and then in blue is the larger uterine volume. And then yellow is the vagina. Now I don't think they're treating the entire vagina here, just contouring the area, the whole vagina. And then this sort of dotted line is what they would contour as a CTV, before accounting for organ motion. For patients with an intact uterus, it's very important to account for organ motion. Now, in this case, you might think that when she empties her bladder, that this uterus is going to fall forward, and in red is her gross disease. But you can see here that in actuality, when she emptied her bladder, it fell backwards. It became retroflexed. And so in this case, and if we fuse these two images, oops, sorry about that. If you fuse these two images, that would end up with a very large, ITV volume. And so I think for this patient, this patient was treated years ago. We ended up deciding to treat with 3D conformal radiation because it was it would have ended up being a larger volume anyway. So this is our next survey. So how do you account for organ motion in patients with cervical cancer? You can go ahead and start. So you do A, a plan of the day with CBCT, B, a full and empty bladder at the time of stimulation to create an ITV, C, you treat with the bladder full consistently or bladder empty consistently, or do you do larger PTV margins with a daily CBCT? Okay, so very few do a plan of the day with CBCT, and this probably consumes a lot of resources to do a plan of the day. We certainly don't do that at MD Anderson, and I think you also have to train your therapist on what to look for, because it's perhaps not practical for physicians to be on the machine every day looking at the plans and selecting the plans. Full and empty bladder at the time of simulation, about a quarter of you responded with that. And that's what we do at MD Anderson. We do a full and empty bladder at the time of simulation, but then we also do a daily CBCT, and then about half say you treat with the bladder either full or bladder empty consistently. Although we also instruct our patients about bladder filling, but we notice too, at least the therapist notice oftentimes when they do their CBCT, that although the patients say their bladder is full, it's actually quite empty. So, I wanted to just talk a little bit about now IMRT for vulvar cancer. So as all of you know here, there are many advantages for treating women with IMRT for vulvar cancer. You can spare the central bowel, you can spare the femoral heads. Women who were treated with, more conventional fields in the past, APPA, had a high risk of femoral neck fractures. You can do a concurrent boost or concurrent simultaneous integrated boost, and you can certainly protect the skin outside of the PTV much better with IMRT. There are a number of disadvantages, though, of course. There is a steep learning curve for contouring for vulvar cancer, and this is because it's a rare cancer, and many of us see very few of these. So even at a center like MD Anderson, we probably only see about 20 patients a year with vulvar cancer, and that's split between 4 or 5 physicians that just treat women with gynecologic malignancies. So we, as a group, we review these cases together in our weekly QA conference so that everyone can weigh in on the patients. We review all of the imaging together with a radiologist to ensure that we are targeting our volumes appropriately. And so this is a treatment technique, so I think this is fairly standard. We do mark the scar or any tumors. We wire the tumor, we frog leg them. And I'm guessing this is probably less of an issue here in Taiwan, but in Texas, we have many patients that are very large. And so we do frog their legs to avoid overlapping regions of skin, but some of these women can have very large, called panises. Their stomach can overlie their groins, and so they can get lots of skin toxicity there. So we obviously check them every week, and they can frequently have fungal infections as well. We use thermoluminescent dosimeters to check their skin dose, and we do a very mild hypofractionation, 2 gray, maybe 2.3 gray per day but only to we do a sequential boost. So, but for the initial 25 fractions, it's usually just 2 gray a day, simply because of the skin dose. So a couple of years ago, the RTOG group published a consensus contouring atlas for vulvar cancer, although it took a number of years to publish, so it's probably about a decade old and probably needs to be updated at this point. But they recommended the CTV include the entire vulva, which we don't always include the entire vulva. If the GTV extends beyond the vulva, to add 1 centimeter margin. And if it does invade the vagina, to treat gross disease plus a 3 centimeter margin. And if there's any question about the extent of vaginal involvement, you would extend that CTV superiorly up into the vagina. Similarly, if there's anus, anal canal, bladder, rectal, periurethral, or periclital involvement, you include a 2 centimeter margin very generously. And I think this is really based on what our surgeons, our GYN oncology colleague surgeons do in terms of how the extent of tissue they remove at the time of surgery. So for a wide local excision, they, I think, attempt to do a 2 centimeter margin. That may not be practical if the disease is approximating a critical structure for them. But that's what we would do in terms of our principles for contouring. So I did want to talk just briefly about the inguinal nodes and specifically, how much margin is really necessary. So this was a older study done about 10 years ago by the Pittsburgh group, Sushil Bariwal, who has a lot of experience treating women with vulvar cancer. And what they did in this study was they looked at where the positive radiographic lymph nodes lie with respect to the inguinal femoral vessels. So were they, and those represented those little dots here. And so based on where they lied relative to those inguinal femoral vessels, he developed this consensus contour. And so we would largely agree with this. However, in our practice, and actually from his data too, there are very few. There are no lymph nodes here that were posterolateral to the inguinal femoral vessels. So we don't typically extend our contours posterolateral. And this is actually very controversial. I talked to my GI colleagues that treat anal cancer, and they will include posterolateral to the inguinal femoral vessels. And in our experience, that just increases the femoral neck and femoral head doses. So I just wanted to poll all of you here today. Do you extend your nodal CTV contour, posterolateral to the inguinal femoral vessels? A, yes, or B, no. And just, oops, sorry. And what I mean is, do you extend it, into this region here? Okay. Sorry. Oh, it's split in half. This is very interesting. Maybe this half that do it treat anal cancer, other GI cancers, but again, it is very controversial. I talked to other GYN radiation oncologists outside of MD Anderson, and many of them, contour into that region. So I just wanted to show you a couple of videos here. Let's see if it starts. Oh, there we go. So this just shows the inguinal femoral contours. In cyan and blue is the CTV contour, and in red is and in maroon are the gross nodes that we're targeting. And so those nodes would get 50 gray. The nodal CTV in blue would get 45 gray. And then we follow on with an additional boost just to those gross lymph nodes. And oops. There's a video here too. Let me see if I can start it. Oh, there we go. So we like to look at the contours in multiplanar view. The nodes are usually anterior and medial to the femoral and saphenous veins here, but they may also lie along branch vessels. And in terms of vulvar contouring, as I mentioned earlier, we'll wire the tumor, because it's very difficult to see on CT imaging and sometimes difficult to see on MR imaging. If you have a PET scan, we would fuse that to the simulation CT scan, but it's not always in treatment position, and the treatment position can be very different. But it's important, I think, to look at the multiplanar view once you've contoured the vulva, We recommend doing an exam under anesthesia if the vagina is involved so that you can place fiducials to mark the most superior extent of vaginal involvement. And we do also try to minimize the high dose to the mons because this can contribute to significant morbidity and lymphedema. Although the RTOG contouring guidelines would suggest, treating the entire vulva, which would include the mons, this doesn't make practical sense for a patient with a small lesion, say in the posterior fourchette, to treat such a large volume. And I'll give an example of a patient with that. So these are the consensus contouring guidelines from the RTOG. On the left is a patient with locally advanced vulvar cancer, and you can see in red, dark red or bright red are the consensus contours, and you can see this patient had locally advanced vulvar cancer. The left inguinal region, there were no gross nodes, and so they didn't include this skin bridge, but on the right side, they did. Now, it may be because this patient was thinner. I don't think you definitely have to treat that skin bridge, the region in between the groins and the vulva, but this patient, I think, was small, so it maybe just extended there. But as a rule, we don't feel like you have to treat that region, especially in, say, a larger patient. The postoperative, they also provided consensus contouring guidelines in the postoperative setting. So the CTV would include the entire operative bed plus 2 centimeter margin, but in this case, you don't need to extend the CTV to the mons, especially if not initially involved, to help decrease the skin toxicity there. This is a patient that I recently treated in the last year. This is a 59-year-old woman with HPV negative squamous cell carcinoma on the left labia majora. She also had a history of lichen sclerosus, so her labial folds were kind of obliterated. On FDG PET, she did have an FDG avid left groin node and bilateral external iliac nodes with mild FDG avidity. And so this is what her contours looked like. I don't know if there's a video here, but oops. We did end up boosting the 1.6 centimeter left groin node as well as these bilateral external iliac nodes as well that had very mild activity. And in general, are very conservative about boosting. So if we think there's any possibility that there's involvement, we'll go ahead and treat those nodes to 60 gray. I think this is a video. Oh, yes. So I just wanted to show you the axial slices of what we are contouring. So the superior CTV nodes would be at the bottom of the SI joints. And in dark blue is what we've contoured as a nodal CTV. And you can see a couple of left groin nodes that we are boosting. And in red is the GTV and yellow is the CTV. So then we would go back and do a sequential boost to that red volume to, I think we did 66 or 68 gray for her. Okay, I think we... Oh, and this just shows that same patient in her contours in the coronal and sagittal view. Oh, I guess there's a video here. And we like to look at these contours in multiplanar view in sagittal and coronal just to make sure that these contours are smooth and not sort of jaggedy. But you can see here the gross nodes and the CTV. And this is, you can see the wire here. This patient, she had a left labia majora that was involved. And we contoured up to the insertion of the clitoris onto the pubic, up to the pubic bone, and included a little bit of the mons and the distal vagina too. So this is the MD Anderson dose fractionation that we use. So as I mentioned, we do a very gentle integrated boost, so 45 gray to a CTV and 50 gray to the GTV, and then GTV nodes, and then followed by a sequential boost. And the boost to the nodes will be between 60 and 66 gray, depending on their size and whether or not we think they are very suspicious. So small, less than 1 centimeter nodes that are equivocal, we probably boost to 60 gray. The gross nodes get at least 66 gray. And sometimes the GTV primary goes up to 68 or so gray. I think that's my last slide, but I'm happy to take any questions, or I think there might be questions here.
Hi, Professor Lee. Professor Lin, I'm Jenny Chen from National Taiwan University Hospital. Thank you for sharing with us the GIN contouring classes. It's very helpful. I would like to ask, in treating cervical cancer and endometrial cancer, for prophylactic treating the para-aortic lymphatics. So what is your common practice in MD Anderson? I would like to share with you, in National Taiwan University, our practice is now only when there will be 3 scenarios. First, for the definitive cervical cancer, locally advanced cervical cancer who has not been operated. They will refer to us for definitive CCRT. And in that case, only when there are FDG-avid or MRI-avid para-aortic lymphadenopathy, we will treat the para-aortic region. We do not, in most of the case, in definitive CCRT, we do not prophylactic treat the para-aortic lymphatics. That is our common practice. But we have noticed that for more and more international clinical trials, their inclusion criteria will be if there are 2 or more positive pelvic lymph nodes. They will encourage us to treat the prophylactic para-aortic regions. And this is, I would like you to share with us your common practice in MD Anderson. And also in post-op cervical cancer, if we see that it is the pathological, pathological stage 3C1 patient, which means that he had pathological pelvic lymph nodes pathologically confirmed. Will you also treat the para-aortic lymphatics prophylactically? And also in post-op endometrial cancer, which is most of the case, because most of the endometrial case will be will receive staging operation. So if there are also in consensus that if there are 2 or more positive pelvic lymph nodes, would you also treat the para-aortic lymphatics? Thank you very much.
Yeah, so thank you for those questions. And I acknowledge that there are many controversies and many practice patterns. So I'll share with you what we do. By no means is it the right thing to do. But so for your first question about patients with locally advanced cervical cancer who, would all obtain would all get an FDG PET scan at diagnosis, when do we treat the periortics? So we would treat the periortics, certainly if they're involved. So if they're FDG-avid nodes in the periortics, we would treat the periortics, and then we usually go about at least 1 vertebral body above the highest lymph node, or up to 2 usually. But if it's already that the highest lymph node is already at L1, we don't want a very extended field. So it may just be that we treat 1 vertebral body extended, 1 vertebral body superiorly. But otherwise, if a patient has FDG-avid common iliac node, then we will treat up to L2 at least in that scenario. We haven't moved to the number of lymph nodes, but there's some data from the Embrace group that multiple positive nodes grossly on imaging may be a risk factor too for having subclinical periortic metastases, as many of the patients that were treated on the early Embrace studies failed in the periortics. And so I think that's what prompted them to deliver more prophylactic periaortic radiation. So then your next question, I think, was in the post-hysterectomy setting for women with cervical cancer who have stage 3C1 disease. So would they typically have periaortic nodes removed too, or just a sentinel node? Oh, a sentinel periaortic node, which they don't routinely do at Anderson. So they would do, So in that case, we probably would only treat the pelvis in the post-hysterectomy setting, because typically those women are younger, and I think we would just follow them closely with imaging, and if they do fail in the periaortics, then hopefully we would be able to salvage them with radiation. So I would say in general, we don't see a lot of women after hysterectomy for cervical cancer anymore. I think mostly because we do image these patients, and even if they have like one little lymph node that may be equivocal, I think usually our GYN oncologists just prefer to send them to us for primary radiation and chemotherapy. So usually we would just treat the pelvis. So then your third scenario was women with endometrial cancer who have had surgery or hysterectomy, who have a positive sentinel lymph node, like when will we treat the periaortics? So, I mean, there is data now that perhaps, at least retrospective data, that there may be no benefit to doing prophylactic periaortic radiation in that setting. But in our practice, there is some data from our group, from our surgeons who found that deep myometrial invasion and high-grade disease in patients that got a sentinel lymph node biopsy had a high risk of periaortic nodes being positive. So in that scenario, in those patients that have at least 2 positive sentinel nodes and with deep myometrial invasion or grade 3 disease, we would treat their periaortics prophylactically.
Thank you very much.
You're welcome. I don't know am I out of time now too? I see Dr. Chan just walked in. What's the next session? Oh, I think we have a few more minutes. Any other questions? No? Oh, okay, Doctor.
Yes, I'm also treating gynecology cancer, so I
Sure.
really want to ask you that, because recently our gynecology surgeons ask us that what do you like the information about in post-op endometrial cancer. There's like the N0 I positive. Yes, that is the case. And they ask us to do the post-op EBRT for the N0 I positive case, because they think that because the pathologist, just like the breast cancer pathologist, they are going to move the endometrium pathology forward. So they are now classify the N0 I positive case as isolated tumor cells and
right.
lymphatics. Yeah, so in that case, if it is like pathological T1B N0 I positive case, so do you treat the EBRT?
I would say that we always just discuss it in our multidisciplinary tumor board, but oftentimes we will treat, I think we have like 5 minutes. We will treat some of those patients with adjuvant pelvic radiation, and we base that, but they won't, then our GYN oncologists will not give chemotherapy. They will not give the systemic carbotaxol. We would just give them pelvic radiation. And sometimes, and only if they have grade 3 disease would we also add concurrent chemo. Otherwise, so for women who have grade 1 or grade 2 isolated tumor cells, we may just give them RT alone, pelvic RT.
It is also our consensus,
Okay.
just EBRT alone. Yeah, that's enough.
Yes, exactly. All right, well, thank you so much for your attention this afternoon.